Hello, my name is Saba Haile Tegenya, and I am a second year medical student at the Perelman School of Medicine, currently doing my neurosurgery rotation. Today, I'm here to discuss glioblastoma and dendritic cell vaccines with a special focus on a recently published phase 2 trial using allogeneic dendritic cell vaccines. So just to give a very brief overview, glioblastoma is a highly invasive malignant tumor with a median overall survival of only about 14.6 months. And it's a very difficult cancer to treat for different reasons. Partly it's because it's a cold, heterogeneous, and infiltrative tumor with a very high recurrence rate with current standards of treatment. So there's a very clear need for novel methods of therapy. One such candidate is dendritic cell vaccines that have gained prominence in recent years. And the way these dendritic cell vaccines are made is shown in this simple diagram. So glioblastoma tumors are resected from patients and made into a tumor cell lysate. Concurrently, these patients undergo apheresis to obtain peripheral blood mononuclear cells that are then used to generate dendritic cells. These dendritic cells then get loaded with this tumor cell lysates, made into a vaccine, and get administered to patients with the hope of eliciting a strong anti-tumor response. In the case of autologous dendritic cells, peripheral blood cells are obtained from the same patients from which tumors are obtained to generate these dendritic cells. In the case of allogeneic dendritic cells, peripheral blood cells from external donors can be used to generate these dendritic cells. So using this concept, there have been a couple of studies showing efficacy and improved survival using dendritic cell vaccines. One such trial was published in JAMA Oncology in 2022. And this large trial showed that autologous tumor lysate-loaded dendritic cell vaccinations in combination with standard of care resulted in extension of overall survival in new glioblastoma patients, as shown in figure 2, but then also in patients that had recurrent glioblastoma, as shown in figure 3. And this was a very important study, especially because patients with recurrent glioblastoma don't have a standard of care as of now. So the paper that I'm going to dive a little bit deeper into not only confirms this past study, but it also extends the finding using allogeneic dendritic cells. So this was published in February of 2023 in the journal Cancers. And this paper shows that vaccination with allogeneic dendritic cells prolongs overall survival in high-grade gliomas, and it was a phase 2 trial. To get a bit more into the methodology, it was a phase 1 to prospective and controlled trial with 37 patients that either had glioblastoma or grade 4 astrocytoma. The mean age of the patients in this trial was 47. 9 of the patients had IDH1 mutated grade 4 astrocytoma. 28 patients had wild-type IDH1 glioblastoma. And these patients were compared to controls from a database called a Genomic Data Commons, which is a very large database. And then patients received monthly intradermal injections of allogeneic dendritic cells. And I'll go over the scheduling for the vaccines in the next slide, but the maximum dose that was received was 12. So this is a representative case of one of the patients in the study. So this is a 28-year-old with IDH wild-type glioblastoma. So initially, the location of the tumor made complete resection impossible. So the patient only underwent partial resection where 50% of the tumor was taken out and then started receiving chemoradiotherapy. However, 3 months after the initial resection, the patient unfortunately had recurrence. So he had to undergo a second round of surgical resection, followed by 7 doses of this dendritic cell vaccine. 11 months after initial resection, they stopped giving chemotherapy. And as you can see with this MRI FLAIR sequence, during the treatment stage and even after, the tumor size seems to have remained stable. But more importantly, what they report is that the patient seems to have resumed his normal life and recovered from a grade 4 motor weakness that he had on the right. Moreover, the patient was reported to be performing 100% according to the Karnofsky Performance Scale. And at the time of publication of the study, the patient was still alive and asymptomatic 24 months after the trial's initiation. So this finding is remarkable considering the reduced overall survival of patients with recurrent glioblastomas. The paper further looked into the effects of the vaccine into specific patient population. So in A, we're looking at patients with glioblastoma, and the survival was 27.6 months in the vaccinated population compared to 16.3 months in the control group from the GDC database. And so this was a 47% reduction in risk of death at any given time point. In patients with grade 4 astrocytoma, as you would expect, the difference is bigger, where vaccinated patients had a mean survival of 59.5 months compared to 19.8 months in the GDC control group. And this was about an 82% relative reduction in risk of death at any given time point. So overall, this was a positive study showing increased efficacy with the use of dendritic cell vaccines. Overall survival was 75% greater in the vaccinated glioblastoma group and 200% greater in the vaccinated astrocytoma 4 group. Moreover, 7 patients from the study remain alive at the time of the publication of the study. So even if this is a prospective, single institution non-randomized trial that used external controls, it's still a very important study, and it can contribute greatly to the promise of dendritic cell vaccines and the treatment of glioblastoma. I wanted to spend the next few slides discussing a few things about dendritic cell vaccine trials. While the paper that I just presented and a couple other papers have shown improved survival with the use of dendritic cell vaccines, there have also been a couple of papers that did not show improved survival with these vaccines. And one such paper is the one I'm showing on this slide. While it's very hard to pinpoint exactly why there is this variation in results among trials, I thought I could just discuss, potential reasons as to why we're seeing this different results among trials. So one potential reason is the technical use of autologous versus allogeneic dendritic cells. Some trials prefer to use autologous dendritic cells while others are using allogeneic dendritic cells. There hasn't been any one study showing that one is superior over the other, but this is one potential reason. Another is there's a difference in the number of dendritic cells that are administered. Most of administrations seem also to be different between trials. Some trials use intradermal administration of vaccines, while others use intranodal administration. Another is timing and duration of vaccination. How often do patients receive these vaccinations, and for how long do they receive this vaccination? These points also seem to be different among trials. Generation and maturation protocol for dendritic cells is also different. Once peripheral blood cells are obtained, the cytokine cocktails that are used to differentiate them into dendritic cells and then also further mature them are different between different studies. Another final point is the difference in the patient populations that are being studied. Some trials focus only on patients with recurrent glioblastoma. Others are looking at newly diagnosed glioblastoma or a mix of the two. And these patients are also grouped using different criteria. So in some trials, methylation status is used as a criteria to group patients, while IDH status is sometimes used, as in this paper, to kind of classify patients into groups. And so while by no means is this a comprehensive list of reasons as to why we're seeing this variation trial results, but this could be potentially one of the reasons why we're seeing these differences. In terms of future directions of where this field is headed, one potential thing is standardization of protocols across trials, standardization for the generation and maturation of protocols for dendritic cells, and then also possible vaccine dose and scheduling to increase reproducibility among trials. And then also, what tumor characteristics do we use for classifying patients into subgroups, IDH status versus methylation status? Another interesting point to look into is characterizing the immune infiltrates after getting this dendritic cell vaccines. So the desirable immune infiltrates would be Th1 or cytotoxic CD8 T cells that have a strong anti-tumor effect, but some dendritic cell subtypes can elicit a Treg or Th17 response, which is not desirable when it comes to anti-tumor effects. So further characterization of the infiltrates would be very informative. Ultimately, combination therapy for synergistic anti-tumor effect would be ideal. So combination therapy with immune checkpoint blockade, CAR T cell therapy, or immunostimulatory cytokines such as IL-2, or the additional pharmacological blockade of immunosuppressive cytokines such as IL-6 would also be an ideal path for this. These are the references that I used in preparation for this presentation, and thank you for listening to me.